Welcome to Beyond the Frontline podcast, where your host, U.S. Air Force veteran Donna Hoffmeyer, will help you transition from the front line to the home front. Listen every other Wednesday as we'll bring great conversations, resources, tips, and feel-good stories that will resonate and relate. Now, here's your host, Donna Hoffmeyer.
Hey everyone, this is Donna with Beyond the Frontline, and I want to talk about rural care. I'm from a small town, about 1,300, and getting good care, getting almost good anything is really hard because in one sense, we're out where we want to be, where it's nice and quiet and peaceful, but in another sense, it's very hard to get resources. I mean, heck, Amazon, I don't even think they have Prime where my parents live. It still takes a week. So one of the things that's really difficult is medical care and healthcare. And interestingly, I had a reach out from a gentleman, Dr. Moody, and he was like, hey, I'd love to come talk to you about some of the things that we're doing in our business. And so that's what we're going to aim about today is rural care and the technologies that are actually helping with rural care. So let me introduce this fine young man, Dr. Moody. He's the Chief Medical Officer for Accenture Federal Services. He is an Army veteran. He served over 20 years, retired as a colonel. He works with the DHA, the VA, and he works with other federal agencies, leveraging current tasks and state-of-the-art technologies that promote a shift to a virtual-first strategy. Hello, Dr. Moody. How are you?
Hey, Donna, how are you doing?
Good. I'm excited to have you here because I think I was telling you when we were meeting before that the day that I saw the request to come in and I saw the word technology and all the good stuff that the VA is doing with technology, I had just submitted in for the PACT Act, which is completely not where you're working, but I had just submitted and it was a very frustrating process. And I was like, oh yes, let's talk about technologies. But what you're doing is pretty neat. So let's kind of go backwards and tell me about your background. And then we're going to kind of get into what you're doing now.
Okay, I appreciate the opportunity to talk about this, and I think it's not. I would just say for a second, though, it's not so much what our company's doing; it's what we are doing with the government to do things better. Because I think everybody realizes healthcare could be better. So we'll come back to that. Myself, I'm a family physician. I come from one of those small towns in what we like to call LA. That's Lower Alabama, equally small to the one that you are talking about. Where healthcare wasn't always accessible. My father was a quadriplegic when I was young, well before the time of the American with Disabilities Act. So getting healthcare, particularly when you were rural, is difficult. So I grew up in Atlanta, now living in the North Georgia mountains, where healthcare is similarly less accessible. But at the same time, in the modern world, and what we'll get to with virtual first is the world's best healthcare can be there at your door, the same way that I'm recording this podcast with you from vastly different places. So I'm a family physician. I grounded very much into some simple principles, right? That there's only one standard of care, and that's excellence. And excellence is defined as what I expect my mom to get, my daughters to get, my grandchildren to get. And more importantly, the people that deserve the best care in the world are the men and women that serve the country, right? That is the reason that I still do only federal health care. And it's why I say today, right, although Accenture Federal pays me, I work for the men and women that serve the country.
I agree. Absolutely. We fought hard and we should have those benefits at all over the U.S. I think I told you in the beginning, I took care of Guard and Reserve when I was in my last, 5-6 years in the military, and they lived all over, right? So just because they're assigned to a base doesn't mean that they live there, and they could live in very rural places. And I had people that said, I don't have internet service here. I don't have cell service here. I have to drive 2 hours to get to the clinic. Those are big hurdles to have to overcome. And while we know you can't, you have a broken leg, you got to get to somebody. We can't do everything virtual. We understand that. But there's a huge amount that can be done. And so I just want you to get into what you developed and what what you see this going, where you see this going.
Great. So let me do that. And I want to start with a couple of facts, right? Because if you don't understand why there's needs to be virtual first. It doesn't make sense. And so I start with first with a thing that it's my favorite view of the world, which is, and it's person-centric, right? We spend about 100 minutes of our lives with a doctor in a year. There are just over 500,000 minutes in a year. Healthcare, right? The business of medicine spends all its time focusing on those dots of 100 minutes. Now, in the rest of my life, what I like to call the white space, where my friends or my family lives, where I live, is where health decisions are really made. We as patients, right, and even as a doctor, I am more often a patient than I am a doctor, right? And those back to those minutes, patients control 80% of outcomes. They control 80% of decisions, right, that occur around healthcare. I make a recommendation, but you have to actually execute as a patient what you do. And my job is to understand you and help you to do that. So first we have that's one element. And the other element is just as critical. We in the US healthcare system, and it's actually a global problem with doctors and nursing shortage, we have a shortage in access. It's more acute right now in the rural America where hospitals are closing because you can't get access and available. You can't get specialty care if you're going the traditional model. And with the aging of our clinical staff, there's more doctors over age 50 than under age 50, the amount of nurses who have left the profession, although we have more licensed professional nurses in the country than ever before, is creating a crisis. And with that, we'll run into problems with access. That drives up cost, which drives up access problems. And it's a revolving. We have to do something differently. So what virtual first is about, right, is it's a strategic framework. It's a mindset, right? It's how you would reimagine and reinvent healthcare today if you were going to start it today. And you get rid of the sacred cows if I got to go see the doctor in the clinic, unless I have to see the doctor in the clinic. Our healthcare system is largely designed around going to see a doctor in a clinic, physical space that has its own limits, right? It's only open so many hours a day. It's only staffed for a period of time. And we go there for everything, right? If you have a rash on your hand that shows up today, or if you have something significant. Now, we definitely, like you said, if you break your leg, we need an ER to be able to go. We need to go to those things frequently. But with that transformation mindset, right, you go, if I believe that things have to be done differently, and I need to create new standards and processes that really don't distinguish from in-person or virtual care. And I don't mean that it's a hybrid model. Either I go to do something inpatient or outpatient, but the moment that you may, as a patient, right, in that white space of your life, think you need have a question, if you can get that question answered, that might diffuse the whole problem there and it never gets bigger. If you can be engaged regularly and we can be proactive, you stay healthy. So you don't need that hour visit or that 3-hour hospital admission, right? So those are the things that can change. And once you adopt a virtual first mindset, you begin to ask, how do we deliver care differently? And I can use synchronous care, asynchronous care, phone calls. I can do all kinds of things. I'm willing to bet I got three daughters and 10 grandchildren, right? I text them more than often than I would have phone calls with them. And we could have a running conversation for days and we're staying in communication. Seconds at each one of those times. And I can be texting 7 of them at the same time. Studies show doctors can do the same thing with nurses can do the same thing with their patients, right? 10 to 15 at a time or a video. It's just me and you one on one. And then with that, it really gets to the other part of this, right? It forces you now to design care around the person, right? How the person, you're going to interact with the person. Their time is as important as the healthcare system's time because it's a participatory.
Right.
And that gives me a chance to address resources, facilities. Where should I put a hospital? Where do I need a hospital? Where do I have, how many nurses or doctors do I really need? And in my opinion, we don't have a doctor and a nurse shortage, right? We have a process shortage, a process problem. And if we change how we did things, we would have enough that access would improve. And a lot of studies show satisfaction improves. It's not just about convenience. It's about getting trusted care from more conveniently when you need it and not just having to go to the ER because it's the only it's the only place you have to go.
So I was listening to you and what was going through my head when you said, we don't have a shortage of medical, we have a process shortage. And what popped in my head was how far in some senses we've come. And I think one of the examples is like surgery, right? like, I'm a little bit of an older nurse. I've been a nurse for 30 years. It's hard to believe that. But back in my day, when you came in for a surgery, hip replacement, I'll just use that as an example. My parents both had them. That was a week stay, at least 3-4 days to 5 days in the hospital, right? And here I'm hearing the physician say, "Oh, it can be same day surgery," and I was like, "Excuse me?" And we kept them overnight because my parents are rural, they are far away, and so we opted one night to manage pain and then be able to drive the 3 hours home. So totally understand that. Now, listening to you, we're like, because COVID hit, and that did wipe out all my year group. They're like, have a good day. All the boomers are nearly retired, are pretty much done. My year group just got kind of ruined, really, in a way, from COVID. And now we have new generations. And I hear this from my friends. They're like, I'm working with, nurses that have been a nurse on our floor for 6 months, and now they're becoming a charge nurse, and now they're becoming preceptors. And I'm like, holy cow, they're getting into specialty care, which right out of the bat, which didn't happen in my day, back to that.
Right.
So where we are now, I think a huge shift happened, right? And now you're like, hey, it's a process, we can do better. So what do you see as even better? Because I do agree. I think that we do need to do it better, because the last statistic I saw, now it's been a little while, it's been about a year since I've seen it, they are predicting that the nursing shortage by 2030 will be 500,000 nurses short, that they were
Right.
predicting 2030.
That number's pretty accurate from what I looked at a few weeks ago. And the same way with doctors, right? So what's going to change? So I think it's COVID helped, right? I've been advocating for this change for a long time. I've always knew that healthcare could be better. As a family physician, even a young family physician, I knew that most of the patients that came into the clinic didn't really need to be there, and I could take care of them by phone. I just had to get someone to agree that I could take care of them by the phone and not be penalized, or even as an Army physician, for not being productive enough, because I didn't see enough more patients in clinic. Although I could take care of more patients. So that's part of it. And what we're going to see, right, is an evolution, right? More and more of healthcare is occurring in the outpatient arena. We already see that with the time in the hospital. The first surgery that I ever went in on in medical school was a gallbladder. So you remember how those used to be. Those were weeks in the hospital.
Mm-hmm.
And again, now laparoscopically. And that's a great example of how you can do adopt something completely new, and everything around it changes, right? So that once you agree that change is okay, there's a better way to do things. It's amazing the impact that has, how many surgeries can happen, how many bed days are now open, and people are actually healthier with less complications than they had before if that big old storm. So I think we'll see, and our data at Accenture shows, right, that people are willing to accept care asynchronously, virtually. And that's just, I say that because it's just not video. It's texting, it's asynchronous chat, it's using a patient portal in an efficient way, not just because you have a technology. And with that, more contacts will occur. I can, on this very video call, be getting your blood pressure and your pulse and other lab data fed directly to me from your camera too. You don't even have to have equipment at home. Those are the changes that are coming to allow us to put more and more there. So eventually we won't have hospital at home. We will have hospital anywhere, up to the point, right? As long as, until I actually need to do something, like you said, very personalized care. Your parents needed pain management for the night. They stayed there for a reason. But someone that didn't do that could go home, and I could still monitor them, in contact with them. And I can use these same technologies, simple technologies, phone, video, texting, right, to put it in that terms, and decrease the amount of hospitalizations, readmissions. I can improve the diabetic care. So we have less people who are progressing to disease, less people than who need hospitalization because of disease or have morbidity. And because it allows us to have contact regularly and communicate, collaborate. That's what healthcare is about. It's an exchange and interaction. It's not an encounter.
Go back to, you just said this quick, and I just wanted the audience to catch it when you made the comment that we don't need anything but a camera for blood pressure, pulse, respiration. How does that work? Just briefly.
Briefly, through artificial intelligence algorithms using the light that bounces off of your skin, you can now determine multiple vital signs. Can't do weight yet, but you can do multiple others. Increasing number of tests to become that way. So now we have home devices we can send you. We all have our wearables, like my watch we have on. You can collect that data and send it, or even the VA already has the capability to be able during a video session to have you streaming your vital signs to the provider if you're someone who's needs that level of care during a video. And now it's going to be now it's going to be able to do a video, which makes it more accessible. So I don't have to learn how to use this equipment or how to plug it in. I just got a new air conditioner and they put a new thermostat in here that's so complicated. I'm still struggling with it. And instead, all I'd have to do is before the video started is stare at my camera with my head in the face, and it can take my vital signs. Again, imagine what that then opens up for how a healthcare encounter works. You can do your vitals and tell your doctor about what's wrong with you before you even go to the clinic, if you have to go to the clinic.
Right.
Because now that office visit, part of the office visit is more efficient. You can manage blood pressure remotely with real blood pressures, right? Diabetic care the same way. We change the level of care, and it's not about I need to come to the clinic to get things done if there's not a clinic around. I can do things in a much simpler fashion using technology we have. We just have to agree that here's the model that we're going to use to do that and how we're going to use our people to support patients. Because one of the tenets, and we'll hopefully get to several about what virtual first is, one tenet is you have to design with patients' time being as important as staff time. Healthcare right now is designed around how the healthcare system wants to work, and we invite patients in. But if we start at the very beginning and say, what are we both willing to? Our time is both important, and your time driving is time away from family. It's time away from taking care of your patients, but your parents potentially. So if we start to account for that, our use of resources becomes different. Our need for buildings get different. Total cost can go down. Accessibility can go down.
I have to tell you, it's funny when you say that, to remember patients' time is important. There is nothing more frustrating to me than when I have a telehealth and they don't call on time. Now, I can handle 5 or 10 minutes. I mean, I get all that. 2 hours later, and that's the first thought in my head is like, do you not think I don't have things to do? I'm glued to my phone because I have to have an appointment for my child or something like that, and they don't call. Or they call 2 hours later. Very frustrating. So, yeah.
So that's a good point, right? And I think this is one of the video telehealth, and where you get in there because you had a on-demand appointment where you went into a queue and waited, or you had it scheduled because you could do both of those. But it's not the most efficient form of our engagement, right? I mean, like we were talking about texting asynchronously, going back and forth, secure chat. You can do it that way also. There are ways that we can exchange information, and even like the VA, they are still their number. I think it was 9 million telephone encounters for healthcare last year. A large part for mental health, a large part going to rural. Why? Audio only, say phone, right? Audio only telehealth phone is highly effective, and for most cases just as effective. So why don't we use that as our primary mode of conversation or contact for those things that matter? Now the problem with phone call is still one-on-one, and we both have to be there. Where, like you say, if we were doing chat or other as a part, either in isolation or total, you're not waiting, right? Multiple technologies out there for providing your symptoms, getting feedback occurring within matter of minutes. Very little time on the clinician time, decision support built in, support for you collecting the information at a time that's convenient to you instead of waiting. Because wherever you wait, whether it's in my office, in the parking lot, or in the highway driving there, it's all wasted time.
What do you say to the provider that says, but I can't see my patient? And I'll say that maybe like for mental health is a big one. I can't see them.
So what I say is for the patients you need to see, there are definitely things that I need to see, right? And I was going to grab my phone and show you pictures. So my son-in-law was texted me this morning, said, you got 5 minutes for a medical question, right? And literally he texted me the skin rash that he had. I gave him the diagnosis, right, while I was in another meeting, right? And we did all that. So I have a lot more time if I could use my time better. Why don't I? My question having, so this is why part of virtual first is the part is reimagine and then reinvent. If I imagined it was different, if only thing I can imagine is being in the clinic, used to spend a lot of life in the clinic, right?
Hmm.
In the clinic, and I got 20 patients today or 30 patients today at 20 minutes or 15-minute slots. And that's all I think about. I don't have enough time. You know why? So I'm just turning the crank, and every turn of the crank is the same thing. I run 400 meters around the track constantly. No running one lap for you as a patient didn't make my next lap faster because it's all the same. But if I personalize to your need at that moment, I can actually see more patients and more importantly, have more time for my family, right? More time for my mental health,
Mhm.
more time to do things that I really want to do instead of paperwork and administrative, right? So it's about understanding if you're not happy now, we shouldn't leave healthcare. We should reimagine and reinvent it with a virtual first mindset. And then we'll be more happy professionally. And our patients will be more happy because they have access. And eventually, all of us as taxpayers will be happy too because total cost of care is going to do that.
So you are working. I was reading your bio, the DHA and the VA. Are you working to get the military to adopt this mindset?
Right. So so first the VA real quick, right? And not
Sure.
you have to give them kudos. They were the world's largest provider of telehealth up until 2017, and then they upped their game, right? So about 2003 they started. 2017 they went to their anywhere to anywhere care because historically the VA care early before anybody else did it, well before COVID, they started doing video telehealth, but it was facility to facility. So you still had to drive to a VA facility. In 2017, a little bit with our help, let's say it that way, they moved to a different way of looking at telehealth, and then the focus was on how will you anywhere to anywhere to your home. Now they do more home telehealth visits than anyone else. It's by like 8 or 9 million last year, right? And anybody, even in low bandwidth areas, can get that care. So those great kudos to those and to the VA. And they also have started adding and asynchronous things, and we can talk potentially about some of the other things like Annie, which helps to support people continuously in an asynchronous model. DHA is under the excellent direction of Dr. Toledo Crosland, the DHA director, started what she calls for care to be anytime, anywhere, and always. And so it is their digital first strategy, and they're pivoting to start to go the same way. Been doing so for about a year. They are adding in video. They've been doing that for a while, and they've made an increased investment to make that happen. But it's just not the technology; it's the processes that you put in place. So I think it's coming along. I think you're going to see it across healthcare. Healthcare is always slow to change, and that's
Hmm.
why I encourage with podcasts like this patients to ask in demand for what's available and ask people why they're not doing it. It is the push and pull, the equal benefit from the payers, as we like to call them, the insurance company providers, those people that deliver care, and patients asking for better. And we all should ask for better,
Eh,
expect better.
That is
That
a
makes
very important uh, understanding for people. I tell them you can advocate. 'Cause in the military, and sir, you kind of get what you get. You know what I mean? Like we come in, we have our appointments, we fudge our PHAs all the time because we're just trying to get through so we can go back to the mission. Like that's our focus, get back to the mission. And we don't really advocate for ourselves. We just kind of take what we got and then we kind of move on. And I tell people when you come out of the military, like you get to advocate. You can advocate in the military too. Don't get me wrong. It's just that we tend to not do that. But when we come out, you know, you if you don't resonate with your provider, find another one. It's okay. It's not anything wrong with that. That not everybody resonates the same. So it's a very important thing to talk about that stuff and say, hey, this would make it easier, or whatnot.
right. And so back to the PHA, the periodic health assessment, it has become digital. You could do more and more of that digitally. It used to be I used to fill up a large part of my primary care clinics and my troop medical clinics just doing these periodic exams. More and more of that is shifted to be able to do digitally. It's not perfect, but it's in continuing to improve with that feedback occurring, and that allows hopefully down the data to be used to make that better in that larger question. I also agree with what you said, which is it's a trusted relationship. So if you don't trust your doctor, find another one. It is part of what you can do. And because of the digital world, you can reach out, right, to that son-in-law I mentioned. He doesn't live in Georgia, right? At least he doesn't live in the mountains with me, right? So you could be remote for within the rules of your state, right?
Right.
You can be distanced from people and still get excellent health care from them.
Yes. And as far as like PHAs and digital go, as long as you're answering it honestly, you'll actually get the care that you're supposed to get. So,
That is an important thing.
so let me go back to one thing here before we kind of wind down. Was you were talking about Annie? Do you want to explain that a little bit more? What you were talking about?
So Annie is a protocol-based text messaging system that the VA put into place around 2016. And so it's all asynchronous. It uses text, the most, I mentioned it earlier, it's probably the most broadly used communication framework in the world. And it's all asynchronous. And so Annie, you can get on what the VA calls a subscription. I still use the old term of protocol, but they can assign you a subscription. You can self-assign yourself one. And it can help support you with anxiety, mental health, blood pressure control on your own, enabling you while the VA has access to the data that you're collecting and agreeing to share. Or it can help you with protocols. Say you can build almost a protocol, anything that can be where I'm going to assess you ask you a question, get some feedback, give you some advice, education. We can have a protocol to say happy birthday, right? Which will keep you connected. And so Annie can be in your pocket. She can help you with your phone, with your personal care, caregiver stress. Can help you manage your diabetes. While your healthcare team can be aware of that's going on and seeing the data. That way you are more empowered. And it does something different from home remote monitoring, where people are just collecting data on you.
Mm-hmm.
The patient's involved. So when Annie sends me a text, and I use her, right? I text back in and say, for blood pressure, I text in my blood pressure BP is something, right? And I put it into the system. It makes me think about it and remember that my blood pressure is important and that someone cares enough. I stay focused on what matters to me, what's important, and I keep that as part of a daily reminder. And these applications, right, have been shown in use, and other ones like Annie around the world, decrease clinic use because people are healthy, decrease readmission to the hospital, manage congestive heart failure so we don't have readmissions or admissions, right? Give people a better quality of life. And it's simple telehealth, but it's highly effective and can be used with other things. The VA has it. They've had it since 2016. If you're a veteran out there and need some support, ask your healthcare team about it.
Okay.
I think it can help a lot of people improve that access for everybody. And then when we need to go see the VA or the Department of Defense for our healthcare, we can see them in person. When we can get support and help to help ourselves be healthier and help our families have less stress, we should do that. Take care of ourselves, take care of our brothers and sisters in arms. That's what we do.
Yeah, and trying to get more towards preventative. So Annie's more like an AI. I mean, that will respond back. Is that correct, or is it?
I'll be careful. Annie doesn't have generative AI capability. It doesn't need that for most things. So Annie's is very simple telehealth, right? It literally is a text. And if you type in blood pressure, the VA knows it was a blood pressure, your blood sugar, your blood glucose. If the question is how stressed do you feel today, and you answer that, that gets
Okay.
a response. And when you give that response, it's just a protocol. It's an if-then question.
Okay.
If the patient gives me this feedback, but evidence, right? Evidence shows this works tremendously well. I think that there are great things that generative AI and AI are going to do, but that's going to consume a lot of electricity. It's going to be more costly. Mobile apps have been created for the same sort of things that Annie does. And when compared, simple telehealth is just as effective. So if it's convenient and it's effective, we should use it, right? And when necessary, we use other tools, just like we use video. We need video, phone call, we need it. And when you break your leg, please don't try to take care of it
Don't,
on a text.
don't
Go to the
telehealth
TV.
that. Well, and so it's just basically prompting with questions and prompting you for information. It's not giving you answers. That's where your medical
Right.
team comes in.
It will give you feedback. I want to be clear though. It gives you
Right.
feedback. It will give you based upon your answer, and it's something that a human has already decided, right? So won't hallucinate on you. If you tell Annie, if you tell Annie that your blood pressure is unusually high, she'll give you advice back. But she's not making that up. It's
It's all
device that was
protocoled.
scientifically already established and says, here's the response I'm going to give. And if I get this response so many times or this pattern, I'm going to give the patient directions to do things, advice, which could be to call your doctor and have a video call or go to the doctor in the clinic, right? But it's not AI. It's not artificial in any
Right.
way. It's scientifically built for those protocols, and again works and is proven effective for our medical audience. It's like hydrochlorothiazide. It's a blood pressure medicine that's been around forever and still works
And it
today.
still works. I like ECTZ. It's the first place to go. All right. And so one last question on this, just if somebody, texted in and said, I'm struggling, mental health or something like that, does it have that ability to connect them to or give them 988 or do something? Because I know this is medical, and I want to make that clear to the audience. This is medical side. And mental health, yes, it's also medical, it's your brain, but we kind of in that world have two avenues of that. So
So I'll answer to two questions I heard there. So Annie can be used for medical and administrative needs, anything in preparation for something medical and mental health. It's used protocols for subscriptions for each of those.
oh, okay.
In her current state, if you text in something that she doesn't recognize, she responds appropriately to say, I didn't recognize that, and if you're having a problem, please contact a healthcare provider.
Okay.
Right. In her evolution, the VA and DoD both are, like most of healthcare, is exploring the appropriate use, trusted, safe use of AI, and those type of capabilities are being added. I'm not, again, they're just not available today, and you and I both were in the military, so we know not to say, and it's going to be available at some
Right.
point at this point in the future, because when that point is may change, but the ability to have that conversational agent work and give you direct you to other things you asked for will be coming in the future.
Okay, that's perfect. And you have to start somewhere. I mean, you don't, nothing comes out as a complete perfect thing.
Right.
You have to start somewhere. So the fact that it's starting, and it's been around, but it's starting, we have Annie, and then eventually these capabilities add on. And I just said that because what I don't want to happen, and I say this to the audience, is I don't want somebody to go, oh, I can text this and they can connect, and then it doesn't work for them and they're like, what the heck? Just be clear. We are starting.
So
Go ahead.
just to go one deeper on Annie. So remember, people can self-subscribe. So if you're a veteran and you're enrolled in the VA, you can go download download the Annie app right now, or begin to use Annie. To self-enroll, you could do that through the Annie app, which you can download. You need ID Me or one of the other VA login accounts to do that, but you could start using that yourself, and no one has to subscribe something to you. The other mode of Annie is that the clinical staff can decide that you need to be on a protocol with good scientific evidence to put you on something to help with your self-care support or monitoring, studies on colonoscopy support, getting more tests to be completed, high patient satisfaction, like say, prevent your readmission if you live a long way away. If you think about it, it's deviceless remote patient monitoring without having to have all those things that in your house that you don't want to have monitoring everything you do. You just got to text back to your friend Annie, who's going to take care of you.
Great. And so we have all these, I saw the links here, and we have all these links that you gave us. So we'll put those in on the show notes so people can see that. So, all right, let's wrap this up, because I think this is pretty neat. It really is going to help the rural people. And you know what? The urban people that, I don't know. I live in San Antonio, and let me just tell you, Texas does it big. We decided that we are going to do construction on every major highway at the exact same time. So when I just got back from an appointment, a matter of fact, VA, across the city, and I just hung my head this morning like, oh Lord, like here we go, because you don't know what you're going to run into. So yes, it is important for the rural to reach out there and get them, but it's going to help the urban people too, because we don't want to drive through all this stuff. And if we can avoid those commutes to go an hour for 10 miles, we're all for it, you know?
I can't emphasize that enough, right? That standard of healthcare should be the same regardless of where you live. I mentioned at the outset, my dad was a quadriplegic. If you think about veterans who have been injured and immobile and at home, even if they live across the street from the VA medical center or a military treatment hospital, that's a long transport if you don't need to be there. These technologies reach out to meet you where you are in your life in that wide space and can support your family. A lot of stress can be taken away. You can get your questions answered that's most appropriate with the most appropriate resource to you. And again, that's what healthcare should do. Take away your total stress and improve your medical.
Yeah, I agree. I think it's the win-win, right? It helps the staff that's working there, that's doing their best. It helps the patients, both rural and urban. And I think that as this evolves, it's just going to continue to be a bigger win. So I think that's great. Cool. All right. Well, I'm going to wrap this up. I think this was informative. Dr. Ron, I thank you so much for coming on. This was great. The links will be in the show notes. So if you guys are interested in getting the app for Annie, it will be there for you. And from all of us here in our parent podcast, Coming Home Well, we thank you guys for listening, following, sharing, all that good stuff. Keep getting it out there. If you listen here, you can also listen on our Coming Home Well radio stream that has going 24/7. And we just love having you. So you guys have an awesome week, and we will see you on the next episode.
Thanks for listening to Beyond the Frontline, a podcast of Coming Home Well. Join us every other Wednesday. And if you enjoyed this episode, please share it with others, post about it on social media, or leave a rating and review. Thanks again. And until all are home and all are well.